Psychotropic medication and the elderly.
I'm Nicole Minna.
I'm Stacy Thomas.
And I'm Kathy Scott Marble. Our presentation will cover Section 1 is the DSM-5 changes to delirium and dementia. Section 2, the state of psychosocial interventions for elderly clients. Section 3, pharmacological treatment of dementia from the 20th century and into the 21st century. Section 4, commonly prescribed psychotropic medications in elderly population. Section 5, aging and assisted living. Section 6, side effects peculiar to the elderly. Then we will have a counseling section, and then referrals, and then our references. The new old age. People today are living longer and better, and this is attributed in part to better education, healthcare, and nutrition. 50 is called the new 40. A common marketing play to sell methods to live a higher quality of life through pharmaceutical models and tests are based on aspiring oldsters that are not representative of the population of mental health professionals. Old age seems to be culturally defined as a degenerative process of the body and mind. But in most developed countries, age 65 is defined as being elderly. I'm covering Section 1, the DSM-5, changes to delirium and dementia. The American Psychiatric Association has made several changes, moving from attributing causation to dimensional perspective now, highlighting the developmental and lifespan issues that include gender, race, and culture. Incorporating the latest research and clinical expertise, there is an exploration of biomarkers discussed with etiology and genetic testing. The differential diagnoses are distinguished comparatively. Neurocognitive disorders are a new addition to categories of the DSM-5. They were previously referred to as delirium, dementia, amnestic, and other cognitive disorders. NCD is a preferred term to dementia. Distinguishes dementia not associated with degenerative aging, such as impairment secondary to a medical disorder. Major and mild NCDs. The definition of dementia is Latin for madness. The DSM-5 tried to reduce the stigma of replacing dementia with major and the mild NCD. No single disease is called dementia. This may arise from Alzheimer's disease, Parkinson's disease, Huntington's chorea, and Pick's disorder. The primary characteristic is declining cognitive function and not a deficit. It is separated from neurodevelopmental disorders. The cognitive deficit present at birth or developmentally impairing. It is possible that an NCD could be present with an ND, and we know more about NCD etiology than any other DSM disorder. There are major and mild NCDs. The major NCDs are more severe impairments and severity of impairment of independence than the mild NCDs, and they're essentially dementia or amnestic disorder. The mild NCDs, main purpose for mild NCD category is debated for non-medical mental health professionals. The interest is in detecting early detection and intervention of NCDs, like mild NCDs may be the early stage of later major NCDs. The hope is to maintain and improve and stave off the decline so that therapy can help people make the most of the time that they have suffering from the major NCDs. The mild NCDs may be normal aging for some people. And for these people, medication can only deliver side effects. The etiological subtypes, major NCD and mild NCDs include, that is Alzheimer's disease, Parkinson's disease, Lewy body disease, Huntington's disease, vascular disease, traumatic brain injury, HIV infection, Pyron disease, bivone spongiform disorder, frontotemporal lobe degeneration, substance or medical-induced dementia, and other causes. Alzheimer's disease, the majority of the medication for dementia is for Alzheimer's, which is abbreviated AD. The most common type of AD is cortical dementia and progressive neurodegenerative diseases. This involves an irreversible loss of cholinergic neurons. There's two variations. There is an early onset familiar form that seems mostly genetic, and then there is a late onset form that is far more common and less rooted in genetics. In 2013, the cost to the United States was over $200 billion annually. The predominant problem are thought to be neuritic senile plaques, and they're abbreviated NSP, and the neurofibrillary tangles, NFT. The NSTs are composed of beta amyloid deposits key to neuron death. NFTs are the modified tau protein. The amyloid cascade hypothesis is the most popular theory for the last 20 years, and it suggests that the beta amyloid accumulates, and the problem is production and removal of the beta amyloid. The main alternative hypothesis centers on the tau protein. AD medication. The ultimate strategy of the AD medication is to develop neuroprotective agents that modifies effects of the beta amyloid or medication that flushes before it builds to dangerous levels up in the system. Drugs treat the symptoms, not the underlying causes. Symptoms include cognitive decline, behavioral disorders, movement difficulties, mood and anxiety symptoms, and radical personality changes. Cognitive, functional, and even physical activity level deficits can be present in the early stages of AD. Can Alzheimer's be prevented? Studies suggest that with education, complexity of occupation, and engaged lifestyle can be productive effects. Exercise is associated with the reduced risk linked to the vascular health. Vascular health clinical trials are contradictory. There have been studies that have found the use of antihypertensives often after a cerebral vascular event are associated with a reduction of cognitive impairment. And the recent studies, though, show that people that are over 80, a reduction in the vascular problem occurs, but not in the cognitive impairment. Correlated with Alzheimer's risk, there's a lower level of education, physical inactivity, suffering from depression, smoking, hypertension, sleep, and disordered breathing. The influence of diet is more controversial, and this suggests that possibly omega-3 fatty acid or a Mediterranean diet could reduce one's risk of having Alzheimer's. Several planned ongoing prevention trials are happening, and one is the anti-amyloid treatment for asymptomatic AD trial for asymptomatic and pre-symptomatic individuals with genetic factors. And the drugs in these studies have failed to show improvement on trial. The ACHE inhibitors are the most common drugs to treat Alzheimer's disease efficacy. Donepezil or Aricept, the symptoms are not, the drug is not given until the symptoms are present. So none of these drugs, these three drugs that are here, are going to be considered to be prophylactic. The rivastigmine or Exelon, the transdermal It has less side effects than the pills. So one of the side effects that is lessened is with nausea. The other one is with, there's decreased caregiver burden and an increased treatment adherence when you use the transdermal. The galantamine or razidine is the third drug, and these drugs bind to the enzyme ACHE and break down the acetylcholine. The side effects are gastrointestinal distress, abdominal cramping, and sometimes anorexia. So the major limitation of these drugs is that they show modest improvement at best. Tolerability is generally the guide for which drug to use. So it depends on the side effect that the elderly person might experience. The disease may overtake what the medication can do, and in time, if the patient lives long enough. Newer treatments, there is a new drug called memantine or Namenda that is a NMDA receptor antagonist that acts on the glutamate system. There are more dropouts with the ACHE than there are with Namenda. Namenda shows more benefits if there are moderate to severe symptoms. Parkinson's disease is the other common neurodegenerative disease, and it occurs in 1% of 65 to 69-year-olds, and that is worldwide. There is a progressive loss of the dopamine neurons. We can only treat symptoms and disease that may overtake the drugs. The primary drugs to treat Parkinson's is to try to decrease the dopamine neurons and the dopamine agonist. There are 4 drugs that are used for Parkinson's disease. Levodopa or carbidopa is the most common drug. Apomorphine or apocaine, lariceride, rivotril, or pramiprazole, or also called Miraplex. The Parkinson's disease medications, these drugs partially reduce the motor features of Parkinson's affects the 5-HT and NE neurotransmitters that may account for Parkinson's-related depression. As time goes on, each dose becomes less effective with this disorder. The COMT inhibitors, tolcapone or Tasmar, may lengthen effectiveness of the levodopa or carbidopa. There are possible severe side effects on the liver, however. A side effect of levodopa is induced dyskinesias. The drug induced abnormal movements. The dyskinesias may be treated with a glutamate or adenosine receptor antagonist. Other drugs that have modest effects on Parkinson's are amantadine or Simatril, which is an antiviral, or memantine or Namenda, which is one of the new Alzheimer's medications. Stimulants as a dementia treatment. There is cognitive enhancement that is linked with stimulants as well as the ACHI drugs. The 20th century to the present, caffeine and amphetamines have been used to treat all aspects of dementias. Several studies have concluded negative symptoms of apathy, motivation, and persistence may be responsive to the methylphenidate, or it's also called Ritalin. Frontotemporal dementia and abnormal risk taking has been treated by Ritalin. It has been shown that coffee drinking may be a mild neuroprotective agent with reduced risk of Alzheimer's. And this may be related to caffeine or antioxidant properties of the coffee. And this study was done in 2010 that was called Cardiovascular Risk Factors, Aging and Incidence of Dementia. The cannabinoids, many peer-reviewed studies have supported Cannabinoids that they say they have protective properties that can treat neurotoxicity and neuroinflammation. They may limit the neuritic plaques and slow Alzheimer's disease. Studies show cannabinoid and synthetic cannabinoid prevents brain cell death after exposure to amyloid plaques in animals. Biggest barrier to federal research is the criminalization of cannabis. As state decriminalization expands and federal prohibition will end, allowing unfettered scientific research.
Okay, now I'm Stacy, and I'm going to pick up where Kathy left off, and I'm going to talk about some psychosocial interventions for the elderly, for elderly clients. One of those, one thing is the functioning of the elderly can be affected by social and coping skills. So what psychosocial interventions does is takes these experiences they have and try to create interventions to deal with the social and the coping skills. Utilizing psychosocial interventions along with medications have been proven to support elderly patients in adjusting to factors that may be associated with aging. And as you know, some of those factors can be mental illness, depression, and cognitive impairment. And it's important to properly assessment by clinician of these psychosocial experiences are critical to creating interventions that will support them for helping them with the social and coping skills. Major depressive disorder affects 20% of individuals over the age of 65. So with this prevalence of MDD in the elderly population, there has been a rise in completed suicides in this community. Psychotropic medications such as hypnotics and benzodiazepine can increase the risk of suicide in the elderly community. There are also factors to consider are comorbid disorders such as heart failure, cancer, diabetes, also create increased depressive symptoms. As you know that when individuals have chronic disease, they are depressed. So these things contribute to that. All of these factors should be considered when you're looking at creating interventions. And elderly clients may not respond to the medications a lot, but psychosocial interventions can be used. And something to consider is, as a clinician, making sure that you are, a lot of times the elderly patients want you to understand what they're going through. Doing this when they're depressed, they definitely want you to identify with that. Okay. So one of the first types of therapy that can be used psychosocial is the problem adaptation therapy, and it's called PATH. It focuses on the client's environment and integrates support from individuals, caregivers as an emotional support system while assisting the client with tools to navigate their environment. So it really focuses on looking at their ecosystem to support them. They're going to look at the home, the caregiver, and the client. And it invites participation from caregivers in supporting treatment if needed. So some individuals may be in a different situation, so it can be used without, if they may not have someone that's going to be helping them all the time. And PATH is going to be conducted in their home, and it reduces the depressive symptoms that are associated with aging, and it reduces disability in clients with cognitive impairments. And one other thing also is that it is very focused and it's specific. So that's one thing. It's going to work on those specific things that they need to work on. And they say that it is a better treatment it works better than supportive therapy. Another intervention is interpersonal psychotherapy, and it's called IPT. It can be utilized as a treatment for depression in the elderly, and it's often used to replace general medical care. And it's been proven to increase mental and social functioning. So it definitely works on the interpersonal efficacy of the client, of elderly clients. The techniques used would be communication building. You're going to identify those symptoms. So you're going to look at and it takes a close look at any symptoms and really identifying what symptoms are attributed to the issue that they're presenting. And then there's also an interpersonal psychotherapy for mild cognitive impairment, IPT, MCI. It is a modified version of the IPT, and it builds the relationship between the caregiver and the client relationship, allowing the caregiver to really understand what's going on with the client and help support them. And it supports elderly clients who have severe cognitive and medical issues, and also elderly patients who have had adverse side effects to other medications. There's another intervention, the problem-solving therapy for mild executive dysfunction, PSTMD. This is a 12-week session for ambulatory elderly clients. And what's going to happen is in the first 5 weeks, the model is going to be taught. So they teach the model within the first 5 weeks. The last 7 sessions focuses on fine-tuning the model. So it goes back, it looks at any questions that the patient may have, the elderly patient may have, or any anything that they need to go over again, making sure that they understand what the goals are. And then it supports, again, clients who have severe cognitive and medical issues, and as well as patients who've also had adverse side effects to medication. It also involves a 5-step problem-solving model. So the model is the client sets a goal, then they discuss and evaluate ways to reach their goals. They're going to create a plan and evaluate how well that plan worked. And the planning model helps decrease depressive symptoms. So it's a very good model for a lot of times issues that are going to present in the elderly person's life. It's a good step for helping them start from the beginning to the end of solving the problem to work through those issues. Of course, we have cognitive behavioral therapy, another psychosocial intervention, CBT. CBT is a psychosocial intervention. It's going to focus on changing and challenging cognitive distortions in behaviors. It's effective for treating depression in the elderly population. It's most effective after screening for specific cognitive impairments, sensory impairments, and disabilities. So that's something that you want to definitely do, is make sure that you screen for those things first. So with CBT, it takes those thoughts and those feelings, and then they just kind of look at their core beliefs and how it relates to them, if those things are true, and about their future, how they feel about their future, and just really looking at those thoughts that they have and changing those behaviors. It's really good for older clients because they can be memory trained, so a lot of repetition helps. And CBT can be used with a variety of issues with the elderly. Modifications may be needed. So it's a good differentiation for different issues that may be presenting. Okay, we have group therapy as another psychosocial intervention. It's definitely favorable for elderly patients who don't respond to psychotropic medications or individual therapy. One of the limitations could be accessibility, because a lot of times elderly patients are not able to get around or have someone to take them somewhere. So being able to get to group can be an issue. It does empower them through sharing of related issues. So being able to meet with other individuals that are within the same age group as them, who may be having the same issues, is a good thing, because they can talk about whatever issues they may have and somebody else may have them, and it just helps them work through those things. They also have music group therapy. It's very popular. It's non-invasive and it's inexpensive, which is definitely good, because a lot of times elderly patients are on a fixed income. So they need, and usually group therapy or music therapy would be free. A lot of research has showed that music memory lasts longer, because, you can remember a tune from when you were 2. Musical therapy reduces depressive symptoms. It's very calming. It's a calming thing. A lot of times you play music to calm down. And it's also shown, music therapy has also shown to delay cognitive functioning in elderly patients. Some non-pharmacological interventions. One is aromatherapy, and it supports dementia, and that's, of course, different fragrances. A lot of people have the machines in their homes, and it helps support their mind with dementia, reducing the cognitive issues that may be presenting. one multi-sensory intervention. It's called the Para Robot, and it was started an intervention by a Japanese person in Japan, and it resembles a baby seal. So what it does is it helps to elevate the individual's mood. It picks it up, and it's used in place of live animals. So most often, you've seen where animals are taken into senior care centers or different facilities, treatment facilities, to help. Animals are known to pick up the mood for individuals. So that's what it does. The Para Robot has 5 senses: tactile, light, audition, which is hearing, temperature, and posture sensors. It's going to respond to blinking. It responds to tail wagging and voice commands. So at this time, psychosocial interventions are not commonly used for elderly patients, but it's one thing to consider as a future clinician, because you can use an integrative approach to treating those elderly clients. So it may be a little bit of the medication plus this, or either or, but it's something to consider. Okay, so pharmacologic treatment of dementia. Dementia is a decline in memory or other mental abilities. So there has been an increase in psychotropic medications for the elderly, but also an increase in overuse of these medications in facilities or with elderly clients. Most psychotropic medications are used in institutions, and they are given to women more often than men. Geriatric patients usually have comorbid disorders along with mental illness, and I stated that early. It's something to really consider, because sometimes there may be other issues that may have to be dealt with, and sometimes they're not. So it's really making sure that you're looking for those other existing, the comorbid disorders that may be presenting as well. Inappropriate medication use in the elderly is a major functional and safety issue. So within treatment facilities, we're seeing that over-medicating the elderly patients is becoming more common. And a lot of that is due to staff distress in working with patients, and maybe the cause of a lot of the improper medicating them. And a lot of times, sad to say, most often than not, they present a lot of problems. They're agitated or irritated. So they're giving them the medication so they'll, calm down. And a lot of times they could be overworked and overstressed and stressed. One solution was to create a program called PROPER. It's the solution to over-medicating, and it stands for Prescription Optimization of Psychotropic Drugs in the Elderly Nursing Home Patients with Dementia. It was a trial program that was designed to educate pharmacists, physicians, and nurses regarding medication. The plan it involved preparation and education. Then they were going to look at conduct and evaluation and guidance. And it was a trial plan. It never really came to be, but it was very good, because it was looking at the whole system of medicating individuals in facilities. And it was just a good plan, because you always want to go back and look at how things are working and what else that you could do. And it was also like a checks and balance to kind of help you. So it was just a good thing to assist with keeping the patient safe and keeping you out of trouble. Most importantly, clinicians and those in healthcare need to practice ethically. So you always want to err on the side of doing what's right for the patient. Some other commonly prescribed medications, when we're looking at depression, it is a mood disorder that causes persistent feelings of sadness and loss. Adults the age of 65 and older have a suicide rate of 15 per 100,000, with males rate 32 per 100,000. And I discussed that earlier. There's a high suicide rate with depression in the elderly population. It needs to be an integrative approach to treating them. So that would be utilizing the primary care physician and a psychiatric professional. So always working with both of them, because a lot of times elderly patients are more comfortable with their primary care physician, but they may need services that are not, the primary care physician may not be able to offer. So definitely working with them to making sure that you're giving them good quality care and having proper interventions and medication. You also need to consider the risk and benefits when adding antidepressants to any cognitive enhancer. So once again, making sure that whatever you're going to do is going to benefit the client. Positive outcomes, there has been positive outcomes using Lexapro and Cymbalta for depression. And the SSRIs are proven to increase fall risk in elderly patients. Okay. Studies show that the morbidity rate for depression increases with age. While treatment helps the symptoms, there's also a lot of treatment non-compliance is happening as well. Long-term use of these medications that I mentioned for depression can result in severe side effects. They can induce cardiovascular side effects, senior syndrome, as well as other side effects. They may also affect metabolism and risk of elevated plasma concentration of psychotropic medications. So making sure that you really understand what's going to happen if these medications are given, because most times with the elderly population, they present a lot of problems, and this can increase issues with all these problems. Okay. Another, as you know, elderly people have anxiety, which is a fear characterized by behavior distortion. It's a common problem for elderly as they age. If you have any individuals that you know, parents or grandparents, a lot of times when their anxiety is raised, they start to get fearful and scared, and things can get out of control. So that's something to understand. Anxiolytics, such as benzodiazepine, psychotropic medication, is usually used for depression in the elderly. It is also correlated with higher rates of suicides and falls, and is the number one medication that is used when they come into emergency rooms for the elderly. So we've noticed, I think I mentioned before, that there are issues with benzodiazepine. So why, if they're so problematic, why are we still using them? Okay. A lot of times patients use those medications because it's the only drugs they know. They've been using them forever, so they just continue to use that specific drug. A lot of times they don't know how to do the research on anything else, and maybe caregivers, or they don't have anyone to help them to see what else is out there, and they may, just not, they're so comfortable they don't want to ask about anything else. There probably has been some benefits, so that's why they continue to use it. There's always the issue of tolerance and dependence, having a dependence on the medication and feeling that you can't do anything else without it. That's comes up with all types of medication. And a lot of times they prefer the benzodiazepine to SSRIs as antidepressants. They just prefer to use them. Studies show an extended use of diazepines are associated with negative outcomes over an extended period of time for the aging population. So a lot of times they can cause additional anxiety, increase their anxiety, mess with sleep, psychomotor impairment. Some recommendations that were asked there were recommendations for new guidelines of dealing with these medications, with this particular medication. One was to use it for only 30 days or limit prescriptions. So being able to go back to the doctor and just see if it's working, and if not, try something else, but not just writing prescription and allow them to use it over an extended period of time. Okay. Psychosis and agitation, which are common behavior and psychological symptoms of dementia, BPSD, which happens with aging. Of course, psychosis and agitation, you've seen it before. We talked about it with anxiety. It happens a lot with the elderly community. These are always difficult for caregivers because a lot of times they're dealing with this all the time, so it's hard for them it just brings more stress on caregivers. So what they wanted to do was they created the Omnibus Budget Reconciliation Act, and it was created to combat the misuse of psychotropic medications and protect long-term care of patients in long-term care in nursing homes. So what the act was going to do was just working with nursing homes to make sure that they're medicating them properly and there's like a checks and balance. Atypical antipsychotics are used more than neuroleptics. Neuroleptics are considered to be more problematic. In 2005, the FDA issued a warning for atypical treatment for BPSD in the elderly community. Then in 2012, they created the Partnership to Improve Dementia Care, was initiated a training program and research program to deal with BPSD ethically. So once again, going back to that ethical thing, making sure that you're doing what's right for the patient to keep them safe, you out of trouble. Some ethical issues for the elderly being treated with psychotropic tropic medications. One is autonomy. Does the medication provide more autonomy for the client? It may, you may have to look at the family and the caregivers to see if the patient is able to decide what they want to do. Talking with them and seeing if it's something that they want, if it's something they can do on their own, or if it's something that they like. That's an issue. Caregiving that straddles autonomy, family-centric. So a lot of times there are multiple relationships within the therapeutic relationships. So the parent, it could be that the caregiver is closer with the doctor, so they're maybe encouraging them to do certain things. So just as a clinician, just making sure that you monitor that. Elder abuse is an issue. Clinicians need to assess for that. And they need to really discuss those difficult situations with clients and with caregivers, because a lot of times we talked about the stress that comes along with helping the elderly, or helping an elderly parent or someone, or even if you're just working for someone, there's a lot of stress because of all of the issues that may be presenting. So really helping them look at what's going on and finding resources to help combat that stress. Surrogate decision-making, setting up ways to determine medical directives through substituted judgment or advanced directives. So working with your clients to talk about if something happens, that's with anyone, but a lot of times as you get older, there are issues that are going to present. What do you want to happen? Putting something in place to make sure that those decisions can be made. And end-of-life issues, intentionally making end-of-life wishes, durable power of attorney, saying what wants to happen, especially as you get older. This is something to think about. And as a clinician, you want to really see how you feel about these issues, because it can help drive, it may be driving how you treat your clients. Okay.
And then I'm going to pick up with various issues to consider when working with the elderly population. So in regard to aging and assisted living, Medicaid payments for state psychiatric hospitals and institutions for the treatment of mental health was ended in the 1960s. The intended goal was twofold. One, to end the poor living conditions at these facilities, and to remove the cost of burden from the federal government and basically put it onto the states. The goal was to promote better functioning and independence for these former patients in order to help them adapt to community living. What ended up happening in reality was that many patients with psychiatric disorders were placed into nursing homes and geriatric units. And placing them into this managed care system eventually came up with different concerns, such as inappropriate prescribing of psychotropic drugs, as Stacy was mentioning, elder abuse, social stigma, and as well as it was essentially just a blanket effect for all of these elderly clients, instead of really assessing their unique needs and considering the side effects of the psychotropic medications. In a lot of cases, many managed care sites do not have enough adequately trained staff. So as I mentioned before, a lot of them do not have adequately trained staff. Studies show that between 35 to 53% of clients in assisted living take one or more psychotropic medications. And this study went on to show that only 45% of nursing homes have appropriate psychiatric training. Another issue is the ratio of properly trained staff to the amount of elderly clients. Usually there's too large of a ratio. There's too many clients to the trained staff, and that just serves to increase the amount of caregiver burden that's placed on them and increases the risk of restraining them chemically, which is why what Stacy was mentioning earlier, a large risk with assisted care, managed care settings. If there's not enough direct care staff at a managed care facility, there's a risk that adverse side effects to psychotropic medications may go unnoticed. When it comes to working with elderly clients, it's important to remember that due to physiological aging, that they simply react differently to medications than they would to their younger counterparts. Older adults may be prone to different side effects. Studies show that individuals over 70 are 3.5 times more likely to be admitted to the hospital due to adverse side effects of psychotropic medications. As Stacy mentioned earlier, a lot of those include with metabolism, with cardiovascular issues, fall risk, as well as various other side effects. And the number increases if they're using several medications. The biggest concern with this age group is which medications or combinations of medications are causing the problems. Simply because of the huge amount of medications that are being prescribed, there's no way to discern which one is resulting in what side effects alone, or if it's resulting in side effects in combination with others. And, just due to the unique chemistry makeup of each person, that makes it even more difficult to discern. So according to our text, there are some interesting studies between the United States and other countries. So in the United States, benzodiazepines are usually pointed to as the main culprit and are more likely to be criticized for adverse side effects than other psychotropics. However, in other countries, particularly Europe, they point to it's a combination of drugs, not just benzodiazepines, but others as well, and even those that are not psychotropics, some non-psychotropics such as antibiotics are also associated with adverse side effects, such as falls. They also pointed out that antidepressants, anxiolytics, hypnotics, and antipsychotics were also associated with falls and fractures, interestingly in women, but not in men. Again, that may be because of physiological differences, like women might be more prone to osteoporosis, weakening of the bones compared to men. But there's still more being looked into that. And another thing to keep in mind is that culture also plays a role in what is considered acceptable. In Europe, it's more socially acceptable to drink. So elderly clients, if they don't have a drinking problem, they just enjoy to drink socially. In the United States, they go into a managed care setting and all of a sudden they have reduced, if not no, access to alcohol. And that's essentially changing an important part of their livelihood versus they might have access to that in Europe. So in addition to those side effects, there's also dermatological side effects to various psychotropic medications. And these are referred to as adverse cutaneous drug reactions, or ACDRs, which range from benign to life-threatening. So some examples include pruritus, which is itching, red macules, which is like a flat discolored area, papules, which are solid and discolored elevation of the skin, urticaria, which are hives, angioedema, which is swelling under the skin, similar to hives, but it's going to have more of that pronounced elevation, and then alopecia, which is hair loss. Fixed drug reactions, kind of like what you see similar in the picture, are lesions that appear shortly after taking medication, and the photosensitivity and various psychotropics can range. That's why if you look at the side effects, I recommend not staying in the sun for extended periods of time. So like Stacy was talking about earlier, it is important to integrate counseling with medication use. This helps to mitigate the risks of side effects, as well as helping clients to understand what those side effects are instead of just defaulting to a medication. It also helps with medication compliance. Psychotherapy has been shown to be effective when used in conjunction with psychotherapy, with pharmacology. Cognitive behavioral therapy, interpersonal psychotherapy, and problem-solving therapy are often utilized as first-line treatments for elderly clients. And as Stacy mentioned earlier, they are very efficacious. They are effective. With that said, they may be limited in their effect with clients that are in advanced stages of neurocognitive disorders like Alzheimer's or dementia. They may not have the cognitive capacity to be able to fully benefit and participate in these forms of therapy. And that's why screening is important. For these clients, art therapy may be more effective. It has been shown effective at reducing depression and anxiety symptoms, and because it's engaging the client creatively, it's activating different parts of their brain that may not be as affected by the Alzheimer's or the other dementia-related disorders. So as a result, it may be more viable than other forms of psychotherapy. Studies suggest that when medication treatments are combined with group integrated psychotherapy, dropout rates are significantly reduced. Some things to keep in mind with elderly as well as with their caregivers. As a counselor, it is our duty to take into consideration different factors when bringing up the medications. Studies show that psychoeducation in particular is helpful not only for the clients but for their caregivers as well, to inform them about the medications being consumed, about their side effects. And these studies also show that this serves to reduce caregivers' burden somewhat. And as we mentioned earlier, caregiver burden is a real issue, and as the counselors, we need to be willing to bring it up, because caregiver burden, depending on the nature of it, may lead to increased risk of elder abuse or less effective care for the client. It's crucial to discuss the pros and cons of medications and how they will affect the livelihood of the individual, and to make them more aware, not to chemically restrain the client so much as it is to help improve their livelihood. Medication should be used in conjunction with the treatment, not instead of psychosocial treatment. So as Stacy mentioned earlier, there are ethical considerations that we need to keep in mind. To what degree can elderly clients be autonomous with their medication treatment? You know, if they want to be non-compliant, will that affect their stability? Will that affect, the fact, like, to what extent will it affect how they will be able to live? And are they being non-compliant because they don't like the side effects? Are they being non-compliant because of the symptomology of their disorder? There's a lot of things to keep in mind, and it's a careful balance. Medication should be used to improve their well-being, not to chemically restrain them. As we've mentioned earlier, that's associated with a higher risk of over-medicating, and that in and of itself is associated with more adverse side effects. Does medication maintain their safety and independence? This goes in with autonomy. And is the medication worth the side effects? As a counselor, one must keep an eye for red flags signaling caregiver burden and elder abuse. So where do we go from here? In order to increase the quality of services utilized by elderly clients, we need to put an emphasis on quality of life concerns first. Instead of, focusing, like, it's getting caught up in the moment and over medicating them because understaffed, underfunded, can't, it feels like maybe they feel overwhelmed, can't do anything except to medically calm them. That's just barely putting a Band-Aid over the issue and not really addressing it. Instead of focusing on what the caregiver may or may not be able to do, focus ethically on the client, what it is that they want, what it is that their caregivers want. To accomplish this, it's necessary to be aware of what psychotropic drugs are and are not capable of doing. They're not a miracle drug. And the first step to this is to enable funding, resources, and energy for complementary services in order to provide an optimal quality of life. In conclusion, living longer means dealing with more physiological issues. The field of geriatric psychiatry, though in its infancy, focuses almost exclusively on pharmacological interventions and not as much of an emphasis on psychosocial options. And, we've discussed the pros and cons of how that's been addressed. With an increase in the population of older adults and corresponding mental health concerns, there is a need for a complex set of solutions. The one-size-fits-all approach embraced by the pharmaceutical industry is simply not sufficient or adequate to address the demographic shifts and the complexity of this issue. So here we have our referral list, both in the local Stephenville area as well as going into the Fort Worth area. So in Stephenville, we have the Pecan Valley Mental Retardation. We have their website provided as well as their various locations. There's the Stephenville Medical and Surgical Clinic. We have their website provided as well. The Mesa Springs Hospital, which is in Fort Worth. The Mental Health Association of Tarrant County, also in Fort Worth, and then the MHMR of Tarrant County, also in Fort Worth. And then here are all of our references. So we would all like to thank you.
Thank you.
Thank you.